Good morning again, guys. Miss Dolphin, please start the presentation now.
All right. Good morning, everybody. Make sure my internet is working. All right. So this morning we're going to be talking about abnormal labor and induction of labor. But before we do that, we're going to take a look back at normal labor. So what is labor? Labor is a physiological process during which the products of conception are expelled outside of the uterus. Labor is achieved with the changes in the biochemical connective tissue and with gradual effacement and dilation of the uterine cervix as a result of rhythmic uterine contractions and sufficient frequency, intensity, and duration. So, normal labor, called euthanasia. It is spontaneous in onset and at term, which is about 39 weeks. It presents with the vertex presentation, which is the presentation we want. It has undue prolongation, natural termination with minimum AIDS. Yeah, without having any complications at all to affect the health of the mother and or the baby. So the opposite of that will be abnormal labor or dystocia. Any deviation from the definition of normal labor is called abnormal labor. Thus, labor is a case with a presentation other than vertex or is experiencing complications even with a vertex presentation is still going to be abnormal. Anything affecting the course of labor or modifying the natural termination of labor or adversely affecting the maternal and or the fetal prognosis is called an abnormal labor. So we're going to look over some hormones that play a role in labor. So first is estrogen. Now what does estrogen do? It reduces the inhibition of uterine muscle by progesterone. It upregulates oxytocin receptors in the myometrium. It increases the number of gap junctions between spoon muscle cells in the myometrium of the uterus. It increases actin and myosin, which are the proteins needed for contraction in the uterus, and it also increases the production of prostaglandins, which also help the cervix to efface. Oxytocin, hormone secreted by the posterior pituitary gland, causes uterine contractions as evidenced by an increased number of oxytocin receptors in the uterine muscle coming on to delivery. Increased secretion by the pituitary also happens around this time as well, with positive feedback to the posterior pituitary via the stretching of the cervix. Now we have the prostaglandins. These cause an increased production of activity of collagenase, elastase, hyaluronidase, and matrix metalloproteinases. These result in the softening and shortening of the cervix, a process that we also call ripening, and it also stimulates uterine activity. Next, you have corticotrophin-releasing hormone and cortisol, which are stress hormones. They're produced by the fetus and placenta in a positive feedback loop at term. Thought to be triggering the event to initiate labor, even though I think I read somewhere that no one is exactly sure what initiates labor. So all we have are theories. And this is also termed the placental clock. This results in an increased production of estrogen by the placenta. So just a synopsis or ending to what we just talked about with hormonal effects. Throughout the pregnancy, the number of receptors for oxytocin increases. Thus, the uterus has increasing sensitivity to the hormone as the pregnancy progresses. The number of receptors never go away completely and go back to the original number. So sensitivity is going to be increasing with gravidity, meaning the next time you get a child, hopefully it's easier. So the onset of labor, there is no true direct mark to say this is the onset of labor, but these are just things that people see when you present with the onset of labor. You have your true labor pains. You have what they call the show, which is the passing of a mucoid plug, the one that plugs the cervix. And many times it's mixed with blood. And then you also start having some slight internal dilation of the internal os of the cervix. So this is just a recap of labor. Stage 1 of labor, from the onset of labor to full dilation of the cervix, it has a latent phase, which is highly variable, which means that they don't have they don't have a fixed time frame on it. It's different for everybody, and we can't tell when it starts for people sometimes. And then he has the active phase, where the cervix dilates from 4 centimeters to 10 centimeters. And this one does have a time frame. Average duration is up to 12 hours in primigravida, which is people who don't have babies yet, and 6 hours in multigravida. Don't know, I have that part right there. This is a little image I have here to the side. I could barely see it in this, but it was just showing like a little illustration of what's going on. So stage 2 of labor. Stage 2, this goes from full dilation of the cervix to delivery of the fetus or fetuses. And for people who don't have kids, it's 2 hours long. For people who had kids before, it's 1 hour long. Oh, an epidural, if you have an epidural during this time, it adds, I think it's an hour to the time that we have here. So it's propulsive. It goes from dilation until the head touches the pelvic floor, and then it's expulsive. This happens when the mother has the irresistible urge to bear down in like the Valsalva maneuver to push the baby out until it's delivered. This is just a quick diagram of what happens during the stage 2 labor. So I'm just running through this real quick. So at first, the head is floating as it assumes the flex position, and that is it just before engagement. I won't put an arrow on here. Anyway, the second picture is engaged with the pelvic rim, and then flexion occurs, and then baby begins to descend. And then in the next picture, further descends and further descension occurs, and it starts to internally rotate as it reaches one of the narrowest parts of the inlet. Then down here, you have complete rotation. That's the beginning of extension now. Then coming up over here, cut this out the way, you have complete extension, and then it goes down into restitution and external rotation, and now the shoulders lie in the anterior posterior line where it's the widest at this point, so they can be delivered. This is just another picture of the same thing. So the last stage of labor is basically baby done out, baby has been delivered, and all that's left now is the expulsion of the placenta and whatever products of conception has been left behind. And this is a short process. It normally takes between 5 and 10 minutes, but I've seen sources say it can take up to 30 minutes. So now on to abnormal labor. Now labor becomes abnormal, like I think I said earlier, when it does things that's not supposed to happen. So it becomes abnormal when there is poor progress, slow moving progression, or the progress is therefore just altogether. Slow progress sometimes is called protraction disorders, and they refer to slower than normal labor progress. The arrest of progress, which also called arrest disorders, refer to the complete cessation of progress. They may occur in all stages of labor. Initially, I had 2 stages of labor, but I read something said all. So, labor abnormalities. They are a result of abnormalities with one of the following 3 P's. Some sources say 4 P's, but the 3 P's have been more consistent. So, the passenger, basically the baby and everything to do about the baby, his size, his presentation, his position. There's the pelvis or the passage where the baby comes through, everything about it, the size, the shape, the adequacy of the pelvis. the uterus, the cervix, and the pelvic floor. And the last is the power, which basically refers to the contractility of the uterus. So risk factors for poor progress in labor or labor abnormalities. If you're a small woman, if you're less than 1.6 centimeters tall, if you have a big baby, if you have a dysfunctional uterine activity going on there, malpresentation, malposition, if you happen to have an early membrane rupture, and if you have any kind of soft tissue and pelvic malformation like scoliosis, dwarfism could cause something, scoliosis, yeah. So this is a graph we have here, a patograph. So abnormalities in one or more of the factors we just mentioned before, which are the 3 Ps, they can slow the normal progress of labor. And here, what they do on these graphs is they plot the findings of serial vaginal examinations on the pathogram, and they will help you to highlight the poor progress during the first stage of labor. This is a better picture of it. It shows you the key, and it shows you exactly how you compare. Next, so what we're going to do, we're just going to talk for a few minutes about different pathologies I saw pop up relating to this condition. So the first one is dysfunctional uterine activity. This is the most common cause of poor progress in labor. It is more common in primigravida, meaning people who have children, and in older women, and I think I read older women who probably have kids the first time. So maybe if you're over 35, you're more at risk for this dysfunctional uterine activity happening to you. So it is characterized by weak and infrequent contractions. The assessment of contraction in this case can be done by the abdominal exams, external topography, and the more invasive intrauterine pressure catheter, which is not done all the time. I think the external topography could show you the heart rate and the contractions. Ideal contractions you're looking for are 4 to 5 per 10 minutes. Anything less than that, you might be in problems. So dysfunctional uterine activity, what you do, you manage the patients with hydration, IV saline, some pain relief, and of course, emotional support. Don't forget that part. So if a delay is confirmed, you offer the patient an artificial rupture of the membranes procedure, or if poor prognosis remains, you administer the epidural, then the oxytocin, and this is to try and create some contraction movement. So, and all this time while you're doing that, you're monitoring the fetal activity, make sure his or her heart is still within the range. And if this goes on and nothing happens, a cesarean section is indicated. The next one we're looking at is a cephalopelvic disproportion. All right, this is an implied anatomical disproportion between the fetal head and the maternal pelvis. It can be due to a large head, a hydrocephalus, anything could happen, and a small or contracted pelvis, meaning that you're probably very small, or you had some kind of pelvic injury before and it contracted your pelvis, or it presents with probably an android pelvis, or both of them combined together. So relative cephalopelvic disproportion is more common and more often occurs with, of course, malpresentation of the fetal head. So you suspect this is going on if the progress is slow and or actually arrest despite contractions still happening, the fetal head is not engaging, and the vaginal exam shows severe molding going on, and the head is poorly applied in the cervix, meaning that it's barely there. So to manage this person, you give them some oxytocin as well. Well, this was a bit controversial because some books I saw say you take them straight to cesarean section, nothing else, you don't try anything else. And this other one I saw contradicted it, said you give oxytocin. If it's not that bad and you have your cardiography ready to see and observe what's going on, and if it presents in a malposition that you can fix, you'll go ahead with it. But the other book said straight C-section. Oh, and you only give this chance to primigravida women who don't this before. They say if it's a cephalic disproportion in someone who is multigravida, you do not get oxytocin, you go straight to a surgery. So this is just the last bit that's tied up with the abnormal labor. So malpresentations, these result from poor application of the fetus into the cervix. So during that little bit back then with the pictures, when we're watching the fetus descend down into the pelvic rim and into the pelvic cavity, a lot of them like to happen at the area where it's supposed to have the internal rotation. If that isn't done correctly, then you have a chance of messing up what you're supposed to come up with. So the brow presentations are the worst. They're associated with extended metavertical diameter, and that's like what 11.5 I have there centimeters, and that is too large to enter the inlet. So malpresentations are more common in women who have a higher parity, and some carry a risk of uterine rupture if the labor continues in this fashion. So I would assume a C-section is indicated here. Oh, this one, a shoulder dystocia. I saw it underneath the section as well, so I decided to put it in. So a shoulder dystocia is an obstetric emergency. It occurs when the shoulders do not spontaneously deliver after the head comes out. So what happens in this scenario is the anterior shoulder becomes trapped behind or above the pubic symphysis, while the posterior shoulder may be in the hollow of the sacrum or on the sacral promontory. So you're stuck. So predisposing factors to this thing, it happening before, previous shoulder dystocia, having a baby, I think that's supposed to just be baby, of more than 4.5 kg in size. The next one is a big baby clinically with an abdominal circumference in the 95th percentile. Somebody with diabetes, if you're obese, and it also can occur in a prolonged second stage of labor. So if you're gravida, if you're in labor for over 2 hours in the second stage, you have a higher chance of this. And likewise, if you're multigravida and it's over an hour, you have a higher chance of this happening. So the signs: fetal chin pulls back, like it snaps back at the perineum, I guess, after you can't get free. And they call this a turtle sign, I assume, because your head looks like it's in a turtle's shell. So there are no external signs of the restitutional twist that's supposed to happen. Anterior shoulder fails to deliver with contraction. So to reiterate that you're stuck. So for management, the first thing that they said to do was call for help. So then afterwards, when help arrives, the maternal position is changed. So they employ something called a robber's maneuver. So how this goes is they flatten the bed, they retract the woman's knees up to her chest as far as she can go. And what this does is it straightens the sacrum and maximizes the pelvic diameter. And then you add dental traction, I guess, to the baby. And if not delivered after 30 seconds, try the following sequence, which we'll see on the next page, with 30 seconds to try and deliver the baby with each one. So number 2, you place them on all fours, shoulders move to oblique diameters. And then the next one you do is you return her to the supine position. External pressure is applied. Place hands held like you would hold them if you're doing chest compressions on the mother's abdomen just above the symphysis and apply some pressure. And at this point, you're already supposed to perform an episiotomy. And if not already done, then internal rotation, place hand behind the anterior shoulder of the baby and bring it forward. Rotate the shoulders using the posterior shoulder. Now after you deliver the posterior arm. This, I hope it doesn't have to come to that, but a symphysiostomy, which is cutting your pubic symphysis, can be done to help baby be free. Complications of doing this thing: maternal, you could end up with vaginal trauma. You could end up with some bladder and urethral damage, particularly if you get the symphysiostomy done. Symphysiotomy. And of course, psychological trauma after going through all of that. And for the baby, you can have some brachial plexus injury because it's the shoulders that are engaged. And you might have some cerebral palsy from hypoxia if you're engaged too long. And of course, since it's also the shoulders engaged again, you can have fractured humerus, clavicle, stuff that's in the area, and unfortunately, the baby could die. So, and just to wrap up my presentation, I just have some random pictures here. This is a breech presentation with the 3 types of breech: frank, complete, and incomplete. The only one you can't try an external cephalic rotation with is the incomplete or the vaginal breech with. And then you have a shoulder presentation that normally comes from an oblique or transverse lie. So now we move to induction of labor. So induction of labor is basically the planned initiation of labor prior to its own spontaneous onset. And this is also abnormal labor. So what happens is what precedes induction happening is you need to have cervical ripening. And what happens in this case is a series of complex biochemical changes in the cervix, which are mediated by hormones like we saw earlier at the beginning of this lecture, prostaglandins. So this needs to be done before you go and induct anybody. So indications for this thing: post-term pregnancy, if you have chronic hypertension or preeclampsia, if you have any kind of unexplained hemorrhage, antepartum hemorrhage, diabetes mellitus, I think that's one of the main causes for it, and social reasons because people just want to have the babies at a certain time. Or maternal fetal indications, maternal isoimmunization against red cells, acorium ruptures of the membranes. And for the fetal exclusive factors, you can have twin pregnancy that extends that foreign pregnancy beyond 8 weeks, and fetal demise, unfortunately, if the baby dies, and post-maturity. I think this just meant the baby is past due date, so it can come out now. So contraindications: maternal, contracted pelvis, encephalopelvic disproportion, like we just spoke about earlier, that will really impede vaginal birth from going on. Previous classical cesarean section or hysterectomy, because that extra force on that could probably cause a hemorrhage. Active genital, herpes infection. High-risk pregnancy with fetal compromise. Heart disease, pelvic tumor, because of course that will compromise delivery. Elderly, prima gravida with obstetric or medical complications. I think it just means older mothers who are giving birth. Don't know why I said elderly. And cervical carcinoma. Fetal contraindications: malpresentation, meaning you could come in a breech, a transverse or oblique lie, umbilical cord prolapses, or uteroplacental factors like vasa previa and placenta previa. So predictive factors for successful induction. So you look at the period of gestation. If the pregnancy is near to term or post-term, they said it's more likely to be successful. If the Bishop score is equal to or more than 6, that means the cervical dilation is in a good spot. So that means your induction is probably going to be successful. Cervical ripening is favorable, especially multiparous ladies and people who had a rupture of the membranes early, premature rupture of the membranes. So, presence of fetal fibronectin in vaginal swab. Fetal fibronectin is just something that the babies make. So I think if your water breaks or something, you'll find these cells within the vagina. This is just a little diagram of the Bishop score and what it looks like. Just a little something about it now. The Bishop, or somebody named Bishop, produced a scoring system to quantify how far this process has progressed prior to the induction of labor. High scores which indicate a favorable cervix, are going to be associated with an easier, shorter induction that is less likely to fail. However, lower scores, which is an unfavorable cervix, point to a longer induction that is more likely to fail and end up with a cesarean section. Oh, and the maximum score you can get is 13, the low score you can get is 0, and 6 is the score you need to be in the favorable cervix range for induction. So cervical ripening. Once again, cervical ripening refers to the softening of the cervix, and that typically begins to the onset of labor contractions. And if necessary, and it is necessary for cervical dilation and the passage of the eventual fetus. So this is associated a lot with an increase in prostaglandins in the cervix. So sometimes the cervix needs some assistance to ripen. So here are some pharmacological methods. You can give some progesterone receptor antagonists like mifepristone, relaxin, a protein, the hormone that from the corpus luteum, the luteal cervical connective tissue dissolves as supposed to be. So, and then you could also give the prostaglandins, which we saw earlier, are pro cervical ripening. And then some non-pharmacological methods. You have mechanical dilators or osmotic dilators like the laminaria, and it's a seaweed, and what it does is it kind of dries out the cervix area. So what it does is it kind of induces, well, all of them do that. They try to induce the production of prostaglandins to encourage the cervix to rise. When the transcervical balloon too, and the transamniotic saline infusion, which does similar thing to the osmotic dilator, encourage it to dry out. And this is just a cute diagram here of cervical ripening. Ring coming, boy. So induction now, pharmacological. From what I've read, it seems oxytocin is the main one. It is the most common method for induction. You start the infusion at a low rate, and you give increments following every 30 minutes until 3 to 5 contractions, ideally, are achieved every 10 minutes. So this is administered intravenously and can be titrated on contraction and frequency based on contraction frequency and strength. So you give according to how well patient is responding. So there are various regimens out there. I think they're more specialized to places for oxytocin administration. The side effects, however, are uterine tachysystole and fetal heart rate abnormalities. And it can cause a hyperreflexive, like contracting a lot uterus, unfortunately. So fetal heart rate and contractions should be monitored during oxytocin administration. Non-pharmacological means. So you have membrane stripping or sweeping. You have amniotomy, which is just artificial rupture of the membranes. And then, strangely enough, they had nipple stimulation. They said it works. So amniotomy. This is an artificial rupture of the membranes. So basically, what the mission here is to induce the onset of labor via creating stretching of the cervix, separation of the membranes, and which is supposed to liberate prostaglandins and reduce the amniotic sac fluid to try to initiate labor. So limitations of this, it cannot be employed in an unfavorable cervix, of course, because look at the picture, you need to be able to insert the probe. So, and the cervix should be at least 1 finger dilated for this to be able to go in there and do what it has to do. So indications for this: placental eruptions, polyhydramnios, preeclampsia, and it can also be done together with medical induction. And that's a picture of it going in right now. So amniotomy continued. Contraindications to this: intrauterine fetal death, maternal HIV and AIDS, genital active herpes infection, because baby passing through, these stuff could pass to it. So Immediate beneficial effects of the amniotomy. It lowers the blood pressure in preeclamptic patients. It relieves maternal distress that was supposed to be polyhydramnios, control of bleeding, and that's supposed to be hemorrhage, relief of tension in abrupto placentae, and initiates labor. So complications, chance of an umbilical cord prolapse once you pop the sac, amnionitis, which is now exposed for infection. So an accidental injury to the placenta, of course, the uterus or the fetal parts. So the next thing on the agenda is stripping of the membranes. So stripping, sometimes called sweeping, of the membranes means basically a digital separation of the chorioamniotic membranes from the wall of the cervix and the lower uterine segment. The criteria to be fulfilled for membrane sweeping or stripping are the fetal head must be well applied to the cervix, so it must be real down, very descended. The cervix should be dilated so as to allow the examiner's finger to pass through. They say it's painful. And last on the list was nipple stimulation. So basically, it's breast stimulation to stimulate uterine contractions, likely stimulated by the oxytocin levels that go up. So complications that arise, greater pain in labor, uterine hyperstimulation. You can have a cord prolapse. You have a greater risk of uterine rupture. You have, I don't remember what that failure was for, but that was failure to come out properly. Increased need for cesarean section or instrumental delivery, and you can also have a fetal compromise. So in case of an unfortunate unsuccessful induction, the options include attempting an induction again at some point in the future if everything is okay, or going in for the cesarean section. So delaying delivery is only acceptable if there is no major threat to fetal or maternal condition. Failed induction in the setting of preeclampsia or fetal growth restriction is normally an indication to have a cesarean delivery. Oh, it's done. It's done.
Ms. Dolphin,
Yeah, Dr. Williamson. Miss Williamson.
you came to an abrupt ending.
Yes, I didn't realize I was finished either until I saw the photo.
How you mentioned monitoring of a patient during labor. How do you monitor the fetal heart during labor?
What's the
What are
thing called? Autocography? Like you strap it around the tummy and you listen. Some people just auscultate though.
auscultate with what?
A stethoscope or the small, I think it's a pin stethoscope, the specialized one for the situation.
So you can use a Pinart's fetoscope.
Mm-hmm.
Have you ever seen in your clinic or on the labor ward a handheld Doppler? No?
Well, I didn't get a chance to be on the labor ward like that. But I think I've seen a Doppler a long time ago.
What are your normal fetal heart rate values that you're looking for?
It's between 120 and 160 beats per minute. So anything over that is a problem, and anything under that should be a problem.
You mentioned assessing labor progress. You gave
Mm-hmm.
an overall duration. What sort of minimum dilation per hour are you looking for in
I
the
think,
primary graviton and in the multigraviton?
hmm, I think it's like, is it 1 centimeter per 2 hours?
1 centimeter per hour. So
Okay.
1.2, 1.5, a minimum 1 centimeter per hour for the active
Mm-hmm.
stage of labor.
Okay.
How often do you assess these patients?
Well, it depends on how bad it is. Like every 30 minutes.
You mean you want to do vaginal examinations every 30 minutes?
No, I thought you meant listening. I don't think anybody would like a vaginal exam every 30 minutes.
Okay, so how often do you do a vaginal exam during
It
labor?
is hourly too much to ask?
Hourly.
Mm-hmm.
Well, that's a bit too frequent as a
Mm-hmm.
normal rule.
So what is
Uh,
it instead?
in the first stage, you're talking about every
Mm-hmm.
4 hours, and then you cut down to every 2 hours. Then, based on where the patient is, if she's nine
Oh, so you go for
centimeters,
4 hours. Yeah. I
right,
mean, she's ready if she's 9 centimeters.
if she's nine
Almost
centimeters,
ready.
you expect her to be ready. So that will
So
give her another 4 hours. Yeah.
repeat
All
what you
right.
just said. You just broke.
Oh, sorry about that. I was saying, depending on how far dilated she is, then you
Uh-huh.
vary your examination frequency or interval. So if she's four
Oh.
centimeters, you may give her another 4 hours. If she's six
Uh-huh.
centimeters, 7 centimeters, you may give her 2 hours. So it usually ranges 2 to 4 hours, but it can be more
Okay.
frequent depending on how close she is to delivery.
Okay. So the
All
closer
right,
you get, you could size it down to how much?
right. Based on
Like
the
when it,
how long you expect her to be in labor. So if she's
okay.
9 centimeters, you expect her to deliver in another hour, hour and a half. So you're not going to check her in 4 hours. You
Of
understand?
course, yeah.
Right.
Yeah, man.
Okay. Let me talk to some of your senior students. Kevin
Okay.
Fraser.
No, these are not senior students. These are junior students as well.
Kevin Fraser is a junior student.
Yes.
Yes, yes,
So please
doc.
go easy.
Why was I thinking I'm going to be assessing senior students?
No, doc, it's junior students.
But you just managed to reduce your level of questioning.
Thank you.
Uh, well, I was in a senior student mode enough to get my mind back to junior students. What are the basic stages of labor as outlined in the presentation?
So there are three stages of labor, main stages of labor. So stage one is when there's cervical dilation up to 10 centimeters, and that can be divided into a latent phase and an active phase. You have stage two, which you have delivery of the fetus, and stage three is basically delivery of the placenta.
Well, interval from full dilatation to delivery of the fetus, and then interval from delivery of the fetus to delivery of the placenta, yeah?
Yes, doc.
Have you done any reading, the definitions in terms of gestational age? What is preterm? What is early term? What is late term? What is post term?
I think I know what is post-term. Is that greater than 42 weeks gestation?
Yes, so post-term is greater than 42 weeks. What about post-dates?
Repeat.
Post-dates.
Post-dates.
Yes.
Uh, Post-dates are basically after the due date, after 40 weeks.
So 40 plus 1 and beyond is post-dates.
Yes, Doc, after 40 weeks.
What about
And
term?
pre
What is term?
would be less than 37 weeks.
Yes, that's preterm. Good. After preterm, you have early term. So what is early term?
Early term. I would say early term is less than 34.
No, remember preterm is less than 37. So early term is 37 to 38 plus 6.
Can you repeat that?
Early term is 37 weeks to 38 weeks and 6 days.
Okay.
So after early term, you have term. So what do you think term is?
I would say term is 38 weeks.
No, remember we said early term is up to 38 plus 6.
Term is 38 to
39
39 to
to
40 weeks.
40 plus 6.
Okay, Doc.
And then late term is 40 plus 6 up to 42. And this is important because you want to deliver your patients at term. So when you're having a post-date patient, you want to deliver the patient by 40 plus 6. You don't want her to go to late term because it has implications for baby. That's the significance of knowing these dates. So you know how to act and prepare for baby if baby is going to be compromised. So a compromised baby is going to be those that are preterm and those that are beyond late term. You follow?
Yes. Yes, Doc.
What basically causes patients to go into labor spontaneously? What are the interacting factors?
Um, well, hormonal factors play a part, and you have cervical ripening and
So which
stretching,
hormone? Which hormones?
oxytocin and prostaglandins.
Which hormone throughout pregnancy wants to get the uterus ready for delivery? And which hormone is opposing it all along? So there are two main hormones.
Oh, yeah, you
One
mean
is
progesterone and
steroid.
estrogen?
Progesterone is trying to keep the uterus quiet,
Yes, and estrogen
and
is
estrogen is trying to get it empty. Yeah?
yes.
That explains why we use progesterone supplements to suppress patients who are at risk for preterm labor. Because progesterone wants to prevent labor while estrogen wants to stimulate labor. How about the mechanical factors? Are there any situations where you expect earlier labor because of mechanical factors? Distension and pressure on the cervix,
If there's over distension of the uterus,
such as what cases in obstetrics?
repeat.
What patients in obstetrics tend to have an over-distended uterus?
If there's a twin pregnancy,
Yeah, twin pregnancies tend to go into labor earlier.
or a polyhydramnios, or if the
Yeah,
baby is large,
diagnosis.
a macrosomal baby.
Correct. So there are these mechanical factors, and this is made use of in induction of labor when Ms. Dolphin mentioned the mechanical dilators, osmotic dilators, and membrane stripping, etc.
Yes.
Those tend to favor which hormone?
Repeat the question.
Those procedures tend to release which hormone?
Or do you mean the membrane sweeping procedure?
Right. Yeah.
Um, the one that be prostaglandins.
Right. They release prostaglandins, and that
Okay.
those play a role also in initiating labor.
Yes, ma'am.
Um, what would you define to be abnormal labor?
Well, abnormal labor is a prolongation in any stage of labor.
How would you document abnormal labor?
How would I document abnormal labor?
How do you visualize it? What would help you to decide that this labor is abnormal?
A partogram?
Okay, good. Thank you.
Okay.
Shannon Grant,
Morning, Doc.
uh, junior student as well.
Yes, I am.
Okay. Patients coming to the labor ward. She walks in and says, I believe I'm in labor. You're the intern on the labor ward. What's your course of action for this patient?
Um, okay. So immediately take a quick history.
Mhm.
So you'd want to basically find out about if you find out if if she's been pregnant before, find
Yeah.
out about that pregnancy. Um, you'd want to you'd find out about her last menstrual period, her last menstrual period to get an idea of what the gestational stage that she's at,
Yeah.
and you'd 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 find out how well you'd also consider how regular her period is in terms of calculating that as well. Um, and you'd go on to examination.
So you
So,
finish with your history.
pardon me?
You know, go through her antenatal care for this pregnancy. Could there be
Oh
anything
yes,
that's important?
yes, you'd find
Suppose
out
she had
about
an
her anti.
ultrasound showing a placenta previa.
Pardon me?
Suppose she had an ultrasound showing that she has a placenta previa. So you really need to go through the current pregnancy.
Right, right. So you need to check for that to see if you're going to encounter any issues in terms of delivering. To also also in yeah, you need to go through that to find if you have any issues in terms of delivering the baby, and also in terms of determining how the baby will be delivered. Um, also, you'd want to, oh, you'd also want to, yeah, so for the, I think that's it for the history. Well, you go to the antenatal, you go to you find out about the current history, and yes. Oh, and
Do,
you
do, your,
also want to check on her health as well.
do your patients carry an antenatal booklet?
Yes,
So suppose her hemoglobin is 6. Would that be relevant for you?
yes, it would be.
Dolphin mentioned HIV status. Suppose she's HIV positive. Is that important?
Definitely.
So the point I'm trying to get to you is that when you're assessing this patient, you need to look at her entire obstetric antenatal, well, past obstetric history if there's one, and her current antenatal care to see if there's anything relevant to your management of her while she's now presenting in labor.
Right.
All right, so let's get to her presenting complaint. What specific questions do you want to ask her now? So you have perused her records, everything is good. Normal, low risk pregnancy.
Normal low risk pregnancy. Okay. So you'd want to probably find out about vaccination. When
You
she
have done
started.
that. She's
Oh,
on
okay.
the ward now. She's in labor. What
Right.
specific questions do you have for her now?
You want to find out about the pain when it
What about
started.
the yes?
Um, an idea maybe of how regular the contractions are based on her perception of them. Um, Also, you can probably query about the maybe when the water broke when the water broke.
She has that spontaneous rupture of membranes.
Right, spontaneous rupture. You can ask about if she, you can probably query about the show, the
Yes.
mucus plug, if she saw any blood on her underwear, anything like that. Also, you find out about mm, yes, I think you can go to the examination at this point, right?
Okay, you want to go to examination. Go ahead. What
Right.
examination are you perform?
So you go start with the abdominal exam. So we can examine for possible scars, maybe of previous, if she had a previous cesarean section. You
Oh,
don't want
the
to.
patients must be assessed in a general way first. What checks are done by your nurses before you assess a patient? Very critical to the assessment.
Oh, her vitals, so her blood pressure, heart rate, pulse, oxygen. If she's diabetic, that would be important. So you don't want to check on her glucose. So those vital signs.
Right. So vital signs, urinalysis.
Right, urinalysis. Yes.
So your
And then,
Leopold's
mhm. Hello? Doc, I'm not hearing you.
yeah, man, go ahead, go ahead.
Oh, yours? Okay, okay. So after the nurse would carry out the check on the vital signs, urinalysis, and so on, and you do your general examination, you can just see how her general state is. You can see just look at her general demeanor, how she is on. You can look at her, her body, because if she's obese and so on, that's also very important to note if you're going to be delivering your baby. And then you can go on to the abdominal exam. You don't want to check for the lie of the baby. Um, you can also check to see. I think you can do the fifth palpable to check to see if if the fetus has descended. And then I think you can go into the vaginal examination now, and you check to see
Do you know what the physiofundal height is?
symphysiofundal height.
Yes.
No, would that sounds like, so it's the symphysis and the fundus of the uterus, so maybe the distance from the fundus
That gives an
uterus to
idea
the
of how big the baby is, yeah?
okay, yes.
Yeah, so that's important. So go to your vaginal exam.
Right, so for the vaginal exam, so you'd start from the outside in, I believe, I think so. You would check for you check the vulval area initially. You look for any ulcers, any obvious ulcers or warts, any other lesions. You look for any, I guess maybe you can look for any possible lacerations, maybe. Um, uh, you can check for any discharge, because that might be vital. You can look at the can check for. I think it can probably I'm not sure if maybe at this point you can have an idea of how the baby would be at the cervix. I'm not super sure. I think so. Um, yeah.
Right. So you look at a vaginal exam, all you said, plus the effacement, dilatation of the cervix,
Right. Yes.
palpation of the fetal part, presence or absence of membranes, evidence
Right.
of caput or molding. So you're basically deciding, is she latent or active? Okay, we have done that. She's 5 centimeters, clear liquor is draining, head at -1. No caput, no molding. She's in active labor. What's your plan for her now?
Can you please go over that?
She's fully faced, 5 centimeters dilated, clear
Right.
like it's draining. She had spontaneous rupture of membranes. There's no caput, there's no molding. She's contracting 1 in 4 for 40 seconds. What's your plan of action now? She's assessed as active labor.
Okay. So she's just said actively or based on what you told me. She's so far everything is good. So you'd put her in the in position to start delivering the baby.
She's not
Well,
ready for delivery yet. She's five
uh-uh.
centimeters.
Oh well, yeah, that's true. That's a bit in. So you'd start to monitor her with the cardiotocography. You'd attach that so you can monitor the fetus as well as the mother to ensure that the progress is going good so far at that point. Um yeah, so that's what you do because at that point I believe that you're just
Would you put
yeah,
up
you're
an IV access and take blood for CBC and group and cross match?
right. Yeah, so you put up an IV access. Yes, you take blood and do all those in all the necessary tests and so on.
Are you
In
going to
preparation.
offer her, are you going to offer her any pain relief? Or are you happy for her
Well,
to live?
yes. Oh no, yeah, I'd offer her pain relief as well. Right. Right. Hydration and pain relief. And you'd reassure her because maybe at that point she's probably a bit frantic, especially if she's a new mother. You'd want to
Yeah,
just reassure her.
emotional support.
So yes,
So when are
right,
you going to
emotional
check her
support.
again? When are you going to check on her again?
You check on her in the next 4 hours,
Okay,
depending on how everything is going, maybe more frequent.
thank you.
Okay.
Ashley Jap.
Morning, Doc. She has a connectivity problem at the moment, so that is why she's not here.
So you're going to answer her question or give her some time?
Let's give her some time.
Okay. You, Lloyd Jones.
Present, Doc.
Alright. Mr. Jones, your consultant sent a patient to the labor ward for induction of labor because she's post dates. She's 40 weeks and 4 days. You got that?
Yes, sir.
So she's at term based on what we said before.
Yes, sir.
You have done your history, you have done your abdominal examination. What specifically are you looking for on your vaginal exam? She's not in labor. She's just post dates.
Um, just wait. You mean what are you looking for exactly to trying to figure out
What
whether or not she's ready for delivery?
you're going to do a vaginal exam. What is the purpose of your vaginal exam?
To check for cervical rightness. which you can, I guess, evaluate using the bishop
What?
score.
Oh, very good. So you want to assess her bishop score.
Yes, sir.
What is a favorable bishop score?
Greater than 6.
Okay, so 7 and above.
Yes, sir.
What is an unfavorable bishop score?
Less than 6.
No, 6 and below.
6 and below. Yes, sir.
So remember, 7 and above, 6 and below.
Yes, sir.
What is the relevance of this bishop score?
So basically, it's to tell you whether or not the patient is ripened, and by ripened, I'm referring to if the cervix is soft, um, if it's adequately dilated, I'm ready for anything.
Okay, so you're describing to me a favorable cervix.
Yes,
I'm
sir.
asking you, what is the relevance of the favorable cervix to you? So the cervix is favorable. What does that mean to you?
Well, if it's favorable, then induction can begin.
So if it's unfavorable, you cannot begin an induction. That's what you're saying?
Um, or if it's favorable, there's isn't sorry isn't the purpose of being favorable, well, assessing whether or not a patient is favorable, um is to say, well, then, okay, the cervix is ripened, so there's adequate oxytocin.
Well, so it helps you to choose your inducing agent. So
Okay.
if it's favorable, you're going to use oxytocin.
Okay, sir.
If it's not favorable, what agent would you use?
The prostaglandins.
Use prostaglandins, or you could use the mechanical
Or the mechanical.
form of dilators, right? So it
Okay.
helps you to decide what to use, and it
Okay.
also tells you what does it tell you about the prognosis for delivery?
um Well, if it's favorable, it's a good indication. There's a good prognosis that you know induction would be successful.
Yeah, shorter labor, higher chance of success. Unfavorable, lo- longer induction to delivery time, and smaller chance of success. Yeah.
Yes, sir.
Okay, so you've done the vaginal exam and the cervix is unfavorable. So you're going to think of mesoprostal or cytotech induction.
Yes, sir.
What else would you do for this patient in preparation for induction?
All right. And this is after administering the misoprostol.
Oh no, you have not touched her with mesoprostal yet.
So if she's not favorable, sir, then administering the prostaglandins definitely to get her right.
You, is there any antepartum fetal testing that you want to do to confirm that this baby is okay to be put into labor?
Um, CTG. If you do the cardiac rhythm again.
If she's not in labor, what do you call that test? It's the same CTG machine, but the test has a different name,
Or the stress test.
or non-stress test.
Non-stress test. No, that's it.
Non-stress test. With the non-stress test, what are you looking for?
Uh, um, fetal movement, heart rate, tone,
Fetal movement and heart rate.
fetal tone.
What else? No, you're not going to say tone on the seat on the NST. Have you ever seen an NST?
No, sir, I haven't.
Huh?
No, I haven't, sir.
Okay.
Contractions, it could give you an idea of contractions.
Well, remember, she's not contracting. Remember, you want to put her into labor, so she's not contracting.
Okay, okay.
So for the NST, you're looking at fetal movements as it affects fetal heart rate. And you're supposed to be looking for accelerations. You have heard about accelerations?
Yes, I have.
You should see 2 accelerations in 20 to 30 minutes. You're looking for beat-to-beat variability. The strip should not be flat, it should be seesaw shaped
Yes, sir.
or sawtooth shaped. And you should have good baseline fetal heart rate. Should be between the 120 to 160.
160. Yes, sir.
So if that is not reassuring, you're not going to induce the patient, yeah?
Yes, sir.
What else would you do in addition to the non-stress test?
Would you do an ultrasound?
Yes, very good. What are you looking for in the ultrasound?
To rule out any previous, any pass up, is it pass up previa and or
Placenta.
again?
Looking for
Placenta.
placenta location. Yes.
Yes, sir.
That's all?
Uh, fetal line. Can check for that. Is it
Yes,
okay?
fetal line.
Um, fetal movements. You can do an amniotic fluid index.
So you're talking now about the biophysical profile.
Yes, sir.
What does that involve?
So biophysical profile. So as I said before, we check for amniotic fluid index, movements, um, tone, breathing, etc. Gross movements. Yeah. Hello.
Okay, so four things you're measuring, score 0 or 2. Fetal movement, fetal tone, fetal breathing movements, and amniotic fluid index.
Yes, sir.
Okay? And
Yes, sir.
very importantly, you're looking at the umbilical artery flow to see if the placenta has good reserve.
Yes, sir.
Because if not, then the baby will have heart rate abnormalities if you induce the patient and can get hypoxic injury. So
Okay,
it's
sir.
important to assess the patients prior to induction of labor.
Okay,
Okay?
sir. Yes, sir.
What is the standard regime for administering oxytocin?
Yes.
Are you familiar with it? How do you administer oxytocin?
Not, can't recall the regime, sir.
Sorry?
Can't can't really recall. Is it 20 or something? 20 or 40? Normal saline?
No, that would kill the baby. The
Right, no.
standard is 5 units in 500 mils.
Okay, sir.
Not 30 and 40. That's for postpartum hemorrhage. So what rate do you start the infusion? What instructions do you give to your nurses?
not sure. So this is after every 30 seconds you give the oxytocin.
Every what?
Every 30 minutes. Sorry.
So you start at 10 drops per minute
Okay, yeah.
and you increase by 10 drops per minute every 30 minutes
Okay.
until you have optimum contractions, yeah?
Okay, sir.
What is the regime for administering cytotec that you know of? How much cytotec do you give? Do you repeat cytotec? And if you do, at what interval do you repeat the cytotec? And can you give oxytocin after giving cytotec? And at what interval? So those are the three questions I want you to answer now.
All right, all right. Three questions, sir. What was the first one again? Just remind me. How much?
What dose of cytotec do you administer?
50.
50 what?
50 milligrams.
It's actually micrograms.
Micrograms. Okay.
50 micrograms. Okay. That's in the primip
Okay, sir.
or the para 1. Beyond that, you tend to give a lower dose of 25 micrograms.
Okay.
Why are we cautious with misoprostol? What are the side effects of it we're concerned about?
Can cause uterine hyperstimulation.
Yes, and fetal hypoxia. When we just started to use cytotec, we used to use 100 micrograms. And we had a lot of problems with 100 micrograms, so we no longer use 100. We use 50 for term pregnancies and 25. How can cytotec be repeated? The presentation mentioned if she's not going into labor, you may repeat the induction. How often do you repeat 50 micrograms? Can Ms. Dolphin answer that question, the presenter? Where's Miss Dolphin? Any senior students in the audience to answer that question?
Any
Senior student.
Okay, sir. 6 to 12 would be bad, sir.
Alright?
6 to 12 hours would be bad in terms of repeating it.
Yeah, tend to repeat it at about 12 hours. For the 25 micrograms, repeat it every 8 hours. Some persons can repeat it up to every 4 hours, 6 to 4 hours. But we are a bit cautious with it because we have had problems with cytotec, yeah?
Yes, sir.
Is Ashley Yap connected now? Is Ashley Yap connected now? Any questions from the audience for me?
Dr. Williamson, good morning. Could you please go over the dates when you were describing
Okay.
preterm and early term, and so on.
All right. So we have before 37 weeks, that's preterm. From 37 weeks to 38 weeks and 6 days, that is early term. From 39 to 40 plus 6, that's term. From 41 to 41 plus 6, that's late term. And 42 and beyond is post term. There is increased morbidity and mortality for baby preterm and also late term and beyond. That is why when we're inducing a patient for post dates, we tend to go before 40 weeks and 6 days. We want her delivered at term, not late term, not post term. Any other questions for me?
Yes, Doc, I have a question.
Mm-hmm.
When I was reading, I saw that misoprostol and mifepristone, the combination of it, apparently that because of the risk of complication associated with that combination, I read that, and when in the UK they only use it for intrauterine fetal death,
For
but in
mifepristone,
terms of, sorry,
which combination?
mifepristone and misoprostol.
Right.
Right. So, I understand that I know that in the UK they just use it in the case of intrauterine fetal death. Is that the same here? Also, is it that misoprostol alone isn't as bad, because I realize that we're discussing it, so I figure we use it here
Okay.
often.
So misoprostol is used routinely for induction of labor locally. That's prostaglandin E1. We do not have prostaglandin E2, which is a better cervical ripening agent or a pure cervical ripening agent. Now, prostaglandin E1, which is misoprostol, it ripens the cervix plus stimulates contractions. Prostaglandin E2 ripens the cervix but does not stimulate contractions. So in the States, they have prostaglandin E2 in the form of a gel. They have it in the form of a vaginal pessary. And after the cervical ripening, then they administer oxytocin. Here we use prostaglandin E1, which is misoprostol. It will ripen the cervix and stimulate contractions. And that is why we are cautious in applying oxytocin after a patient has had misoprostol, because both will stimulate contractions. And in our local protocols, we do not administer oxytocin until 12 hours after administering misoprostol. We do not use mifepristone for induction of labor. It has been used in the US, as you mentioned, in combination with misoprostol for intrauterine fetal demise. It is available in Jamaica, not legally, because termination of pregnancy, remember, remains illegal in Jamaica. But it is used in Jamaica for termination of pregnancy, not for induction of labor. That combination. You understand?
Oh, yes. I think I was misinterpreting it. I was thinking that they kind of use it in terms of if the not necessarily for termination of pregnancy, but in the case where the fetus died and they want
Right.
to get it out. That's what I was thinking.
Right. Now, it can be used in that scenario. We also use it selectively in my unit in Maypen for example, a patient that has a missed AB, which is an early intrauterine fetal demise that we are managing medically. So we have the 3 M's, misoprostol, methotrexate, mifepristone. Those are the medical management of retained products of conception, missed ABs, blighted ovum, etc. But mifepristone is not readily available locally. Am I answering the
Oh,
question?
yes. Thank you.
Any further questions?
Yes, so you said that E2 doesn't cause contractions?
Correct. It's a pure cervical ripening agent. While E1 ripens the cervix plus causes contractions.
Okay, thank you.
Okay. There being no questions, I wish you guys pleasant rest of morning and you get ready for your next class.
Morning,
There's
Dr. Williamson.
yes.
Yes. Is there normally a hyponatremia after the oxytocin infusion?
Hyper.
Hypo.
Oh, yes. And that's it because oxytocin is a weak antidiuretic hormone. And for
Okay.
this reason, it should be administered with isotonic solution, such as normal saline or dextrose saline, never dextrose water. It tends to be worse if it is administered in dextrose water.
Okay, so it's
The
not a
hyponatremia,
so it's not the dilutional effect, but it's because oxytocin is a weak diuretic,
antidiuretic hormone.
antidiuretic. Okay, thank you.
Okay, all the best, guys.